association. But what blows me out of the water is the next slide. And that is just looking at type 2 diabetes and obstructive sleep apnea association. Type 2 diabetes is the most common diabetes in the United States. It's the resistance type where there's plenty of insulin around, but it doesn't work well on the receptor. And this is a compilation of 4 studies by the different authors listed here. And the average is that, and all of these studies, by the way, are based on PSG findings of obstructive sleep apnea. They had their type 2 diabetic patients come into the lab, and then on the basis of PSG diagnosis, confirm or rule out whether they had sleep apnea. 70% on average in these studies of diabetics which are type 2 have obstructive sleep apnea. Extremely high association. And here's prevalence over time. We know that diabetes is increasing in prevalence, and look at the one to the left where obstructive sleep apnea prevalence is mapped, and that is increasing as well. If you looked at obesity prevalence, that would be going up together. You might expect that they all would run together because they're all inflammatory states. And increasing one is likely going to increase the others. And it's important to know about diabetes and know about obstructive sleep apnea because the mortality is not small potatoes in either condition. People have diabetes, whether you're a man or a woman, and if you track them over 30 years and compare them to a person who does not have diabetes, there's a 30 to 40% mortality rate. That's high. Looking at the other side of this slide, where you have obstructive sleep apnea, and comparing the mortality rate between a person in green who does not have obstructive sleep apnea and a person who has untreated obstructive sleep apnea in red that's severe, there's a 35% mortality rate over 20 years. Significant. Now I want to get to the point of potholes in the road. But I think to this point, I've tried to stress that these are conditions that have a parallel exacerbation. They're highly associated. They have an increased prevalence and they're significant in their mortality. So before we go and try and give you an idea of what to look for, I want to tell you what to be careful of. The first thing is obstructive sleep apnea is found in 20% of normal weight individuals. So if your only screen is for whether or not a person has obstructive sleep apnea as if they're overweight, you're going to miss 20% of your people. And perhaps even more important is 80% of obstructive sleep apnea patients untreated do not feel sleepy. So asking a person who snores and if he tells you, oh, I'm not sleepy, and then saying, oh, you must not have obstructive sleep apnea, gives you a failing mark. Here's the data. This is a study that came out of, or data from a study that came out of Australia by Preto. And what he did is over 20 years collected, he had every patient that went through his sleep lab followed sequentially, and he recorded their weight against the findings of whether they had obstructive sleep apnea. Now, I just looked at over those 15,000 patients that he collected, 2,000 who were in normal weight. Normal weight means a body mass index under 25. 20% of those normal weight individuals had either severe obstructive sleep apnea or moderate obstructive sleep apnea. We're not even talking about mild obstructive sleep apnea here. 20%, that's significant. So I would encourage people to have more parameters than just weight as their screen for whether or not you have obstructive sleep apnea. The next data comes a little closer to home. This actually was produced by Terry Young out of Madison at the university there. What she did is she went out into the community of Madison and grabbed about 900 people and brought them into her sleep lab. She had them record whether they were sleepy or not, but the researchers didn't look at that initially. They just had the PSG studies. Those people who were diagnosed as having obstructive sleep apnea based on an apnea-hypopnea index of greater than 5, the researchers then looked back and looked at what those patients, what they said and whether they felt they were sleepy when they first entered. 80% of those people who had obstructive sleep apnea based on an apnea-hypopnea index greater than 5 events per hour did not subjectively perceive themselves as being sleepy. This is where it's important not to be fooled by subjective sleepiness. Now the question comes up, well, how is that possible? And going to the next slide, I think we have at least a partial answer. This is a study by Van Doggen, and what it shows essentially is that if you're sleepy long enough, you can lose your perception subjectively of how sleepy you are. So your objective sleepiness, your reaction time, your ability to hit the brake continues to deteriorate, but your perception of how sleepy you are doesn't go at the same level of deterioration. If you look at this slide, and he sleep deprived the same individuals now over 14 days, and you can see in the red, every night was 4 hours time in bed. They got to sleep. Then there was 6 hours time in bed and 8 hours. But let's look at just the red one, the top one. So they were only getting 4 hours of time in bed for 14 days. First of all, on the far right, the subjective, how the patient felt, how they were deteriorating subjectively over the 14 days. If you look at that red curve, from, let's say 2 days of the 4-hour time in bed and then the 14-day time in bed, you might see an angle of about 5% in their perception of them getting worse. Now, look at the other side of the fence, the objective sleepiness. And this is measured by a PVT. All that is a reaction time test. So it gives us an objective data. Looking at that angle, that's about a 45-degree slope. No wonder people are running into having accidents on the road. It's not just that they're falling asleep. It's just that they can't tell how severely they're impaired. Their reaction time is not where it should be, but they can't tell the difference between if they're 2 days sleep deprived and 14 days sleep deprived. That's an important issue. Now we're going to get to the observations and then finally some of the recommendations. One of the things, you won't find it if you don't look for it. And I wanted to give our audience some just ideas of what to look for that are not tests that you could do at home. I wanted to then go over some data that shows that CPAP helps diabetes. And it's, again, because it decreases inflammation. And finally, we'll go and show the International Diabetes Federation's recommendations. Now, these are just simple signs and symptoms you can do at home. Remember, there's a caveat on sleepiness, and that 80% of untreated sleep apnea patients do not feel they're sleepy. If you have it, it's a good thing. I wouldn't doubt that the poor focus, the irritability, and the falling asleep and activities are related to the fragmented, crummy sleep that people have when they have untreated sleep apnea. The frequent visits to the bathroom sometimes surprises people. There's more of those in untreated sleep apnea, and the reason behind that is that there's a hormone produced in the atrium called atrial natriuretic peptide. And when you have untreated sleep apnea at night, more of it's produced. That is a hormone that acts like a diuretic, and so people end up going to the bathroom more. And when you have correction of the obstructive sleep apnea, often that disappears. The restless sleep, the gasping arousals out of sleep, the apneic episodes, and loud snoring are all related to the airway obstruction. Morning headaches occur in obstructive sleep apnea because at night when your airway's closed down, you don't have the ability to exhaust the CO2 out of your lungs. It dilates the vessels of the brain, that stretches the nerves that wrap around those vessels, and it gives you the headache. This is the data which has been done by some of the researchers that I have listed on the bottom corner here. When you have obstructive sleep apnea and it's corrected by CPAP, there's a decrease in the inflammation. There's a decrease in the cytokines, and therefore you decrease the inflammatory state that these conditions swim around in and makes them worse. So if we have obstructive sleep apnea and we get rid of the inflammatory state, we decrease the inflammation. Generally, that helps diabetes, it helps obesity. Finally, we're going to the recommendations. I agree with these recommendations. These were made by the task force in the International Diabetes Federation. And what it says is that if you're a professional and you're dealing with diabetes, or you're a professional and you're dealing with obstructive sleep apnea, you have a patient who has obstructive sleep apnea, think about diabetes. If you're an endocrinologist or in internal medicine or family practice and you have a person who has diabetes, think about obstructive sleep apnea because there's a high association. Inflammation of one aggravates the other, and treatment of one helps the other. Well, that's what I wanted to say today. I wanted to thank everyone for listening. If anybody has questions, they'd like to call us or stop by at Iowa Sleep, our office, I'll be glad to, and our staff will be glad to answer any questions and help in any ways we can.